A 38-year-old male presents with high fevers, progressive weight loss, drenching night sweats, and a dry cough. I am showing you his frontal chest radiograph and an axial chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates multiple, bilateral, well-circumscribed nodules and larger masses, predominantly in the mid to lower lung fields, along with bilateral pleural effusions. There is no significant hilar or mediastinal lymphadenopathy. The axial computed tomography scan confirms multiple peripheral, non-cavitating, solid, soft tissue nodules of varying sizes in both lungs.
Based on these imaging findings, what is your differential diagnosis for multiple lung nodules or masses in an immunocompromised host?
In an immunocompromised patient, the key differentials include opportunistic infections, such as fungal, mycobacterial, or nocardial infections, septic emboli, and neoplasms, primarily lymphoma and Kaposi's sarcoma.
If I tell you the patient has a known history of acquired immunodeficiency syndrome with a CD4 count of 60 cells per microliter, and these nodules have doubled in size over the last 10 days, how does that affect your diagnosis?
With that history of severe immunosuppression, the primary neoplastic consideration is AIDS-related lymphoma. Although the rapid doubling time of 10 days might suggest an infectious etiology, AIDS-related lymphoma is highly aggressive and can double in size within days, mimicking an acute infection.
What are the most common histopathological types of lymphoma that affect patients with AIDS?
The vast majority of AIDS-related lymphomas are aggressive, high-grade B-cell non-Hodgkin's lymphomas, specifically diffuse large B-cell lymphoma and Burkitt's lymphoma.
Contrast the typical thoracic imaging presentation of lymphoma in AIDS patients with that of immunocompetent patients.
In immunocompetent patients, thoracic lymphoma is primarily nodal, presenting with prominent mediastinal and hilar lymphadenopathy. In AIDS patients, it is characteristically extranodal, presenting as parenchymal nodules, masses, consolidations, and pleural effusions, often without significant adenopathy.
What virus is commonly implicated in the pathogenesis of AIDS-related lymphoma?
Epstein-Barr Virus, or EBV, is strongly implicated, driving clonal B-cell proliferation in the setting of profound T-cell depletion.
How can you radiologically differentiate Kaposi's sarcoma from lymphoma using nuclear medicine imaging?
AIDS-related lymphoma is characteristically avid for both gallium-67 and thallium-201. In contrast, Kaposi's sarcoma is thallium-positive but gallium-negative.
Describe the typical computed tomography appearance and distribution of Kaposi's sarcoma in the chest.
Kaposi's sarcoma classically demonstrates a parabronchovascular distribution, presenting with thickening of the axial interstitium and characteristic flame-shaped or spiked nodules, often accompanied by pleural effusions.
Where are the most common sites of concurrent extranodal disease in patients with thoracic AIDS-related lymphoma?
Thoracic lymphoma is usually part of disseminated disease. The most common concurrent extranodal sites are the central nervous system, gastrointestinal tract, and bone marrow.
State the critical safety warnings and immediate management steps you would recommend.
The critical safety warnings are rapid disease progression, septic shock from underlying opportunistic infection, and systemic staging neglect. Radiologists must immediately recommend urgent computed tomography, guided percutaneous needle biopsy, or bronchoscopic biopsy for tissue diagnosis. Suggest brain magnetic resonance imaging and computed tomography of the abdomen and pelvis for staging, and advise screening for opportunistic infections. Refer to oncology and infectious diseases.